So thank you for Specialty Med Training for putting this on. My name is Tapley Holland. I'm the CEO of Bridging Biosciences. My background is I've been in the regenerative medicine space for over a decade. And primarily my role before I started Bridging Biosciences was I was the one who was sent into the field to basically to deliver what is published, what is proven. That there's a big education gap that existed between the industry, the people who made PRP, and then what was actually being implemented into the clinical setting. And so that is what my role was, and it stemmed from not only from what is proven, what is published, but also how does it being reduced to practice. And so PRP, the application, the science of it, and also why are we still asking these questions about it today? So let's talk about the application. So you really, to understand PRP, you have to go back and start like, how did we get here? So it was used in cardiology first for hemostasis. It was thought to be an effective agent for controlling bleeding. And so as we moved, forward in history, its applications have expanded. And so its uses and utilizations for many applications, many treatments have gone well beyond cardiology. So, for wound healing, for sports medicine primarily, but sexual wellness and hair transplantation, even gynecological procedures. The use is, there's more of what we know that we don't know what the extent of what PRP can do than what we know it can actually do right now. So the uses of it will not stop. And it's gained notoriety primarily in the public because of it, a lot of sports, a lot of celebrities. Obviously, they have to remain in peak physical condition, and PRP has worked. So it's definitely known, but many people don't know, what it is, and its utilization is going to continue to expand. Because things for erectile dysfunction, are there alternatives? Things for female sexual dysfunction, even autoimmune diseases. So the utilizations for cell therapies and specifically PRP are definitely well understood, and its utilization will be well more understood in the future. So the science, okay, so. Here's what we know, that to regenerate any tissue, the platelets play a critical and important role in regenerating any tissue. So not only we thought that it was going to control bleeding, but the cellular interactions, the paracrine activity, the directing of the traffic when a tissue is injured, when a tissue is dead, the role of the platelets is absolutely critical. And that's because, what's in a platelet? So first, we have to understand where platelets come from. They come from the bone marrow. They're derived from megakaryocytes. They're actually cytoplasmic fractions of megakaryocytes, and then they're released into the bloodstream. And so, but within a platelet, they have different growth factors. Many people have talked about alpha granules, and more growth factors are actually being discovered even today. But they do have these growth factors which have specific purposes and specific functions during the whole tissue remodeling cascade. So again, platelets were thought to only control bleeding, but as you can see, the utilizations from wound healing to orthopedics to gynecological to everything, that specific growth factors, depending on what you're trying to accomplish, are all going to be specific, and they're all housed within a platelet. Well, if we have platelets, then what's in whole blood? Because platelets are obviously in whole blood, but what's in whole blood? Because that's the main component of how you get PRP. So within whole blood, you have leukocytes, you have neutrophils, you have white blood cells, you have red blood cells, and obviously platelets. And here's a good depiction of when you concentrate whole blood, that what happens is these red blood cells and these other cells, they're based on their weight. And so what happens is what's called density gradient separation. And so when things separate via centrifugation, they're separated out based on their weight. And so you have to start with an appropriate blood draw. And so what people need to understand is that platelet counts vary day to day, obviously patient to patient, but the fact that a platelet count varies day to day impacts eventually what your PRP concentration will be. So not only the individual patient, but actually where you get it from. And these are established, these are known, but not widely known, especially in the clinical setting. So where you actually get it from impacts the actual baseline platelet count that you get. So you have whole blood, and you have a volume of it, and it's put into a centrifuge to process, again, via density gradient separation. So here's a good picture to show that, again, what happens is the red blood cells are separated, and the yellow content is what's called the supernatant. And so it basically, what you have here is everything is in the supernatant except the red blood cells. And so then you further separate these, basically the serum part of it, or the plasma, the platelet poor plasma portion of it, until you're left with a final concentrate of platelet-rich plasma. And this is what we know. The pure definition of platelet-rich plasma was first defined by Marx. And what he said in a nutshell was that a pure definition of platelet-rich plasma is 1 million platelets per microliter. And so that's basically on any patient that you see, is about 4 to 6 times over a person's baseline. And so the function of an individual platelet is multifaceted. There's things that we know, that its cellular interaction, its ability to direct traffic, the messenger RNA, different signaling. In other words, if you removed a platelet from a tissue that you're trying to remodel, that you're removing a critical component of what's vital and necessary for that tissue to repair. And so if one were to look at, say, a histology slide and say, am I getting PRP? This is what it looks like under a microscope. And what this is depicting is these little fragments, these little circles right here, are the platelets. And once you centrifuge blood, you can see that what it produces a highly compacted, very dense, sometimes clumped mass of platelets. So what's important here is for everyone to understand that here are platelets, and then once they're centrifuged, that platelets within whole blood are produced highly compacted, highly clumped, obviously in a very dense number. And this is important because for those who are familiar with PRP and how the mechanical separation works, that you need to be homogenizing the final concentration very well. And so the growth factors, what's in PRP, why, what makes it work. The growth factors are almost widely known: VEGF, insulin growth factor. Here's what we can say, that there are a lot of growth factors that are released within a platelet. And what all of these growth factors do collectively is they can stimulate angiogenesis, obviously neurostimulation, but they're all needed together, and they need to be released either localized during a site injection, or they can be released systemically within the blood or the tissue, and the platelets know when to do that. And so this slide is just a further description of what these individual growth factors are specifically responsible for. And if you really take them all, they each have a specific function. What we know is that the platelet within PRP and its function as the powerhouse to stimulate the entire remodeling cascade of injured and damaged tissue. It's a complicated process of many different things that are going on that we didn't know many years ago. But what we do know now is it's well understood, and we know that we can harvest this bedside, we can harvest this right in the office, and these things could be administered point of care. So why, of all of these known long-term benefits across many applications, why is there still a controversy over PRP? Not all PRP is the same. So if we talked about what's in platelets, we talked about that you have to separate them via centrifugation. We talked about that you have to do the blood draw. If you try to put all those together, it's how you prepare the PRP in your clinic, in the bedside, that all matters. And so let's take, for example, the white blood cells, critical with any type of tissue genesis, critical for the good kind of inflammation. We know these things are critical. However, there are machines that do density centrifugation that actually pellet these out. And one might not know that when selecting a machine, is this happening? So there's plenty of evidence on this, and there's actually this slide really depicts just some of the centrifuge options that exist today and their ability to produce monocytes. Not all of them do that. And so that's critical when you're selecting a centrifuge. The takeaway is what we know today is that the monocyte is a critical PRP constituent. There's plenty of evidence to support all of this. And so much of the evidence within the literature today highly focuses on the machine component, and rightly so, because that is the main mechanical thing that one physician is relying on to produce things that they otherwise might not know. And so the performance and what a machine is able to produce is critical. The components of it and its performance, and the amount of platelets, the amount of monocytes, all of these different things that we saw other than red blood cells that are in that supernatant, all of those things are needed. And they're all needed for a specific function at a specific time during tissue remodeling. Well, if your machine is removing some of it, not giving you some of it, or not giving you enough of it, all of those things matter. And so that goes to the heart of the question. If someone has been doing and administering PRP for a long time, that could lead one to say, well, why do some patients may work and why do some not? It could be right in the heart of the machine you're using. So the literature has well established this. This is one thing that I can say that there is no controversy that the machine that you choose, what it produces, is absolutely critical. And here's the thing, is that a lot of this education is disseminated by sales reps. And so physicians simply, sometimes it's just hard to really sit there and really dig through the literature. It's just not really at your fingertips, nor would it be. So you're trusting sales reps and companies to deliver a marketing message. What would be prudent is to ask questions, is to consider this information, is to be educated on what you're delivering, and because it's only going to get bigger. The options are only going to get more, and the ability for one to choose a suboptimal piece of equipment as part of your armamentarium is only going to be more likely. So that leads us to, how do we standardize all of this? How do we progress the therapies from what we know? What we do know is that regenerative medicine, PRP, is not going away. We saw many slides ago that the applications for it have expanded exponentially, and that's only going to continue. And the more we know about it, the more applications we're going to find for it. So it's going to expand exponentially in the next decade. And so that's important to understand, because the consumer themselves are becoming really educated. They do have the time to maybe just ask very insightful questions that you should have answers for. And even the patients themselves, you should have questions to make sure that what you're getting is optimal from the physician. So education here is the key, because down the road, especially with the passing of the 21st Century Cures Act, which basically says that we're encouraging the expansion of regenerative medicine. If we have applications for regenerative medicine, the risks are known, and we understand that. Basically, we want you to almost investigate it, find cures. So this means that PRP is and other applications are here to stay, and the awareness of it is only going to get more. Meaning the education on both the patient and the physician's side should it's that much more critical as part of the piece of the process. And PRP is going to be combined with other treatments. There's going to be there's more we don't know about the clinical benefits of PRP or other cellular regenerative medicines independently, combined with one another, that we will find out. So, and we will find cures for many different disorders and diseases. So at the end of the day, if we don't have standardization around any of these regenerative medicines, specifically for PRP, because it's the most widely known and it's the most widely established, and there should be some sort of standardization. And if we don't have any type of standardization, who suffers? Really the patient, and really the advancement of the therapy as a whole. So, our mission is to use the most current scientific and clinical data to drive these protocols, to drive this education and best practice of decisions, so we can advance regenerative medicine. And that all starts when we're all doing the same thing. So I applaud Specialty Med, because the advantage of having an entity like this has taken up the mission that they're trying to drive the most scientific and clinical data to establish these protocols, because we've already established that PRP works. Then why haven't we progressed past where we are today? And so therein lies the crux, which is an education gap, is both on the consumer and the physician end. And so when we all get on the same page and we were all making informed decisions, then that's how we advance everything. And so education is a critical part of it, and that's why I started Bridging Biosciences. That's why I left the company I worked for, because I saw over the years of disseminating this education, of implementing these therapies, of being this critical education piece, that Specialty Med did not exist. And the most common question I was asked over and over was, how much do I aspirate? And why would someone ask that? This is when they've gotten the education. This is when they've made informed decisions about the kits they're using. They're asking how much to aspirate, because prior to centrifugation, there's a critical number of cells, or in this case, platelets, that is critical to translate what we know will therapeutically work. And so I started Bridging Biosciences and developed, in collaboration with a physician, the Transcend PRP protocol. And what the PRP protocol is it gives physicians a method and a protocol for quality control. And the whole purpose is if we know that for certain therapies that there are established, proven therapeutic concentrations, we know this. How do we translate this? And do the same tools exist in the scientific setting that are in the clinical setting? The answer is no. So here's what we do know, that there are proven therapeutic concentrations that are established for certain procedures and certain clinical applications. We know this. How do we do that? We have to test a person's baseline platelet count. Then you would import it into our software, which would give you an exact aspiration blood volume for each individual patient, so you can achieve that proven therapeutic concentration. Then you know how much you need to centrifuge. Then post-concentration, you need to validate. Did I get platelets? Did I get the right amount? And so the software also makes adjustments for that. If you got too much, it'll give you a dilution calculation, so you can make sure that you're in that therapeutic range. And why is that important? Because we know that from many clinical established studies that if you don't have enough, it can lead to no clinical benefit. If you have too much, it could lead to inhibition. So it's kind of, people say the sweet spot. I called it the Goldilocks, but there is a range. And there are ranges for known procedures, and those different from what you're trying to do. And the more we know about regenerative medicine, the more we will know what these ranges are. And so hence the reason why someone would need to be doing quality control, because you need to be administering consistent therapies to each individual patient if these things are proven in order to get consistent outcomes. So, how do we reduce this all to practice? We've learned what platelets are. You've made informed decisions about your machine. You've implemented an element of quality control. And so what does that mean? That means that patients are no longer being treated based on the predefined amount of the centrifuge kit. Patients can receive variable amounts of aspiration volumes because that's what they need. But every patient receives the exact same therapeutic concentrations. And if you understand and help patients understand why and what they're getting, why you're going through the hassle of doing quality control, why I chose these specific devices to implement this method of quality control, they will pay more, because the clinical outcomes will speak for themselves.